Thank you. So now we'll move on to anthrax vaccines with an introduction by Dr. David Stevens.
Good morning. So on behalf of the anthrax work group members who are listed here, I want to present the session for this morning. I want to thank Robert Atmar and Sharon Fry, co-members from the ACIP who are on this working group, the ex officio members, the liaison members, and the invited consultants, and Willie Bauer, who's been our CDC lead. This work group was reconvened in March of 2017. The purpose, as I think most know, the U.S. government stockpiles medical countermeasures, including anthrax vaccine, and CDC provides guidance for vaccine use and other aspects of preparedness should there be a widespread or wide area release of Bacillus anthracis spores. The work group considered the body of evidence since the last review in 2010 for policy changes to optimize the use of anthrax vaccine for use prior to and following wide area release of Bacillus anthracis spores. Today's session will be an informational session on the use of a new anthrax vaccine, AV7909, for post-exposure prophylaxis. There will also be a policy vote on a change to the pre-exposure prophylaxis booster dose interval for persons who are not at current risk of exposure to anthrax. The ACIP Anthrax Work Group will stand down after the MMWR policy update is published, and it is anticipated that the work group will be reactivated in 2021 to 22 to review the AV7909 phase 2 and 3 data that are currently in progress or are planned, and additional data on booster dose intervals of greater than 3 years for pre-exposure prophylaxis. And with that, I'll turn it over to Dr. Bauer.
Thank you, Dr. Stevens. And I would also like to thank everyone for attending here this morning, and particularly the members of the work group on the ACIP committee that have provided sage advice over the last 2 years. And so we will go ahead and get started. So this is an outline of today's presentation on the next generation anthrax vaccine, AV7909. Today we are presenting information on the use of a new anthrax vaccine, AV7909, for post-exposure prophylaxis following exposure to aerosolized Bacillus anthracis spores when anthrax vaccine absorbed or AVA availability is limited. Currently, AVA is the only approved vaccine with an indication for use as post-exposure prophylaxis in persons with exposure to aerosolized Bacillus anthracis spores. We are presenting data comparing the immunogenicity and safety of AV7909 administered as a 2-dose series 2 weeks apart compared to AVA administered as a 3-dose series 2 weeks apart. This is a unique policy issue for the ACIP committee. AV7909 is not currently a licensed vaccine and would only be available for emergency use. We are presenting information on this vaccine to ACIP now because we believe it is important to review the data in this open forum prior to a public health emergency. In the event of an anthrax event, we will convene an emergency meeting of ACIP and review this data plus any new data generated since this meeting and ask ACIP's recommendations regarding the use of this vaccine under an emergency use authorization. Before presenting the data to support this vaccine, I would like to provide some background information that is important for understanding the use of anthrax vaccine for post-exposure prophylaxis. There are four types of anthrax characterized by the route of spore entry into the body. Spores introduced through the skin lead to cutaneous anthrax. It has an incubation period of between 1 and 14 days and can have a fatality rate as high as 24% if untreated. Spores that are introduced through the gastrointestinal tract lead to ingestion anthrax. It also has an incubation period of between 1 and 14 days and can have a fatality rate as high as 40% even with treatment. Spores inhaled into the lungs lead to inhalation anthrax. After gaining entry, Bacillus anthracis spores are thought to either germinate locally or to be transported by lymphatic cells to regional lymph nodes where they can germinate. Spores inhaled into the lungs may not germinate immediately, and incubations periods of up to 43 days have been documented. This is why vaccine is recommended after exposure to aerosolized spores to protect against the late germination of spores after antimicrobial prophylaxis has been discontinued. Inhalation anthrax mortality rates have improved in the age of modern critical care medicine, but are still as high as 47% even with treatment. Injection anthrax is a newly described form which has only been documented in Northern Europe. It has only been seen in injection drug users who used heroin contaminated with spores. Anthrax is usually a disease of herbivores that ingest spores while grazing. Humans are secondarily infected by handling infected carcasses or consuming contaminated meat. Historically, inhalation anthrax has been seen as an occupational risk in textile mills that process animal hides that were contaminated with spores. Today, rare cases of inhalation anthrax are seen in persons related to work or hobbies that involve animal hides, such as drum making. However, we know that Bacillus anthracis is one of the most likely pathogens to be used as a bioweapon. Bacillus anthracis spores are relatively easy to produce, can be stored for a long time, and can be dispensed in the air through a variety of means. In addition, inhalation anthrax is highly lethal, and the spores may survive in the environment for greater than 40 years. A wide area release of aerosolized spores over a densely populated area could cause widespread illness and death among unprotected persons. In 1979, an accidental release of anthrax spores from a Soviet bioweapons laboratory in Sverdlovsk resulted in the deaths of at least 60 persons in the community that were downwind of the facility. Also, in 2001, Bacillus anthracis spores were sent through the U.S. Postal Service, resulting in at least 22 cases of anthrax and 5 deaths. To illustrate the potential public health emergency that a release of Bacillus anthracis spores could produce, this graphic using data from U.S. government sources shows a hypothetical release of aerosolized Bacillus anthracis spores along a commuter rail line in a major metropolitan city. This model predicts that the spore plume drifting over a densely populated area could potentially expose hundreds of thousands of persons to spores who would require a combination of antimicrobials and vaccine post-exposure prophylaxis to prevent disease. Post-exposure prophylaxis for anthrax requires early use of antimicrobials to prevent disease until the vaccine has a chance to produce a protective immune response. Currently, the only licensed anthrax vaccine is AVA, which is FDA approved for both pre-exposure and post-exposure prophylaxis of anthrax. Doxycycline, penicillin G, ciprofloxacin, and levofloxacin are FDA approved for the antimicrobial component of post-exposure prophylaxis to prevent inhalation anthrax. The manufacturer of AVA is Emergent Biosolutions. AVA is a cell-free filtrate derived from a virulent Bacillus anthracis grown in culture. The primary antigen is protective antigen. AVA contains aluminum as an adjuvant and two preservatives. AVA primes the immune system to recognize and block PA, which is common to all anthrax strains. Vaccine efficacy against numerous anthrax strains have been demonstrated in many animal studies. For post-exposure prophylaxis, AVA is given by the subcutaneous route as a 1-month priming series at 0, 2, and 4 weeks in conjunction with 60 days of antimicrobials. AVA was last reviewed by ACIP in 2009, and recommendations were published in 2010. ACIP recommended 3 subcutaneous doses at 2-week intervals. At the time, AVA did not have an indication for post-exposure prophylaxis, so the vaccine would have been used under an emergency use protocol. This recommendation extended to pregnant and breastfeeding women as well. The data that supported the safety for use in these populations came from the use of the vaccine for pre-exposure prophylaxis. There were no data for use in children, but the committee felt that given the high risk of mortality related to anthrax, that the vaccine could be given to children under investigational new drug protocol. Since the last ACIP review of anthrax vaccine in 2010, there have been slight modifications to the licensed indication. In 2015, AVA was licensed for post-exposure prophylaxis in conjunction with antimicrobials in persons who have been potentially exposed to aerosolized Bacillus anthracis spores. In 2018, ACIP committee voted to allow the following policy changes. The intramuscular route of administration may be used if the subcutaneous route of administration presents clinical, operational, or logistic challenges that may delay or prevent effective vaccination. In immunocompetent individuals, co-administration of antimicrobials may be discontinued at 42 days after the first vaccine dose or 2 weeks after the last vaccine dose, whichever comes later. And should there be inadequate supplies of AVA available for post-exposure prophylaxis, dose-sparing regimens of either 2 full doses or 3 half doses of the AVA may be used to expand vaccine coverage. Now I will go over AV7909 or Nuthrax. AV7909 is an investigational anthrax vaccine under development by Emergent BioSolutions in pursuit of licensure with an indication for anthrax post-exposure prophylaxis. AV7909 is similar in composition and manufacturing process to AVA. It consists of the licensed AVA vaccine combined with a novel adjuvant, CpG 7909. CpG 7909 is a synthetic immunostimulant designed to induce both an enhanced antigen-specific antibody response and a natural killer T-cell immune response when used in combination with vaccines. AV7909 is anticipated to be added to the U.S. government's strategic national stockpile starting in July 2019. It is also anticipated that AV7909 will replace currently stockpiled AVA for post-exposure prophylaxis as the stockpiled AVA expires. CDC has requested FDA's permission for emergency use of AVA or AV7909 in conjunction with appropriate antimicrobial therapy for post-exposure prophylaxis of anthrax through a pre-EUA submission. The intended use of AV7909 under this proposed EUA is administered as a 2-dose series 14 days apart intramuscularly in conjunction with appropriate antimicrobial therapy in adults greater than 18 years of age, including individuals greater than 65 years of age, pregnant women, and nursing mothers with suspected or known exposure to Bacillus anthracis. It would also be used under an investigational new drug protocol for those less than 18 years of age. Now I will describe the public health importance of this vaccine. While the U.S. government's anthrax post-exposure prophylaxis response plans for a large-scale event include both vaccine and antimicrobials, the currently stockpiled quantity of FDA-approved AVA might be insufficient for vaccine coverage in a large-scale aerosolized anthrax attack, such as I described previously. The availability and use of AV7909 under an EUA would increase the supply of anthrax vaccine and response capability to provide vaccine protection should a mass anthrax event occur if the available stockpiled AVA is insufficient for the necessary vaccine response. In addition to augmenting vaccine supply to enable an effective vaccine response, AV7909 may provide the following additional advantages. 2 intramuscular doses of AV7909 administered 2 weeks apart may provide protective immunity 1 to 2 weeks sooner than the licensed 3-dose post-exposure prophylaxis regimen of AVA. The 2-dose schedule of AV7909 has an operational advantage in a large-scale mass vaccination response and potential for better patient compliance with completion of the vaccine dose series in comparison to the licensed 3-dose post-exposure prophylaxis schedule of AVA. Also, with fewer injection site-related adverse events observed with the intramuscular route of administration for AVA compared with the subcutaneous route, it may be reasonable to anticipate that AV7909 administered intramuscularly may have fewer injection site-related adverse events compared to AVA given by the subcutaneous route of administration. Now I will present some of the non-clinical data the work group reviewed, but first I will briefly describe the assays used in these studies. The anti-PA IgG assay measures the total amount of IgG against PA, or protective antigen, in micrograms per milliliter. It is a species-specific assay, so interspecies measurements may have some systemic biases. The toxin neutralization assay, or TNA, measures the ability of antibodies to neutralize the toxin. It is species neutral, so measurements between studies are comparable. TNA can be reported in raw or normalized units. The raw unit is effective dilution 50, or ED50, the dilution that neutralizes 50% of a fixed amount of toxin. The scale is from approximately 50 to greater than 10,000. The normalized unit is NF50, which is the ED50 of the sample relative to a known reference standard. The reference standard ED50 is approximately 500, so the scale is smaller, from approximately 0.1 to greater than 10. Inhalation anthrax is very rare, so we cannot directly assess the effectiveness of AVA for post-exposure prophylaxis in humans. For this situation, the FDA has recommended using the animal rule, where data from animal and human are bridged to determine correlates of protection that can be used to predict human survival based on antibody titers generated by the vaccine in humans. AV7909 was tested in guinea pigs and in non-human primates. In the guinea pig model shown here, 2 doses of AV7909 at days 0 and 14 provided complete protection in all animals with measurable TNA titers when challenged at day 28. The day 70 challenge had 1 animal with a measurable titer that died. The 70% predicted protection levels are shown. The non-human primate model was performed the same way. There was only one non-human primate at day 28 challenge with measurable TNA titers that did not survive, and 2 from the day 70 challenge set. The 70% predicted protection titers for AV7909 are shown and are significantly lower than the same predictive level of 0.56 for AVA. The studies showed that AV7909 is highly protective in animal models. The 0.15 NF50 titer level has been proposed by Emergent Biosolutions as the target protective level for the phase 2 human trials at day 28. Note that the phase 1 trials achieved levels almost 10-fold higher than this, suggesting that AV7909 should be highly protective in humans. Now I'll review the clinical immunological studies the work group reviewed. 3 clinical studies have been completed as part of the AV7909 developmental program, in which 342 healthy subjects were enrolled, 241 of whom were exposed to the combination of AVA plus CpG 7909 in various doses and immunization schedules. A total of approximately 100 subjects between the ages of 18 and 50 received 1 or more doses of the AV7909 formulation currently under development. I will summarize the important findings from these studies. The initial Phase 1A clinical trial assessed the safety and immunogenicity of AVA mixed with CpG 7909 in 69 healthy subjects between ages 18 and 45. They received either AVA alone, CpG 7909 alone, or a combination of the 2 agents. Vaccinations were administered intramuscularly at day 0, 14, and 28. The TNA assay results for arms receiving AV and AV7909 are shown in this figure. The geometric mean peak TNA concentration for the AV7909 arm was 8.8-fold higher than that observed for the AVA alone arm. The median time for each to reach geometric mean of the highest peak TNA concentration for subjects receiving AV7909 was 21 days, a 25-day acceleration over the mean 46 days it took for AVA alone arm to reach this concentration. The TNA assay results paralleled those observed with the anti-PA-IgG, and both were statistically significant. The primary objective of the Phase 1B study was to evaluate the safety and tolerability as determined by adverse events incident rates for 4 AV7909 formulations compared to placebo and AVA alone. Geometric mean TNA values after intramuscular administration on day 0 and 14 are shown in this figure. Safety and immunogenicity data allowed for the selection of 0.5 ml AVA plus 0.25 milligrams CpG for use in the Phase 2 studies. The primary objective of this Phase 2 study was to assess safety and immunogenicity as measured by TNA NF50 values for each study arm at day 63. The study was designed to assess both 2 and 3 doses of AV7909 at 2 dose levels, as you can see in the study arms listed here. Immunogenicity was measured at the various time points listed. The study was designed to look at comparability of AV7909 and AVA at day 63, as at the time of this study, AVA was recommended in conjunction with antimicrobials for 60 days. Analysis of the AV7909 TNA thresholds of protection data revealed that addition of the CpG 7909 adjuvant to AVA improved the kinetics and magnitude of the immune response. 2-dose AVA 7909 was found to be comparable to 3-dose AVA given intramuscularly at day 63, but achieves peak response at day 28 versus 45 for AVA. Now I will present some of the clinical safety data the work group reviewed. During clinical testing in which a total of 241 subjects in 3 completed clinical trials were exposed to a combination of AVA plus CpG 7909. Systemic reactogenicity manifested primarily as mild to moderate fatigue, muscle aches, and headaches. The most common injection site reaction were mild to moderate pain, tenderness, and arm motion limitation. These reactions were often resolved within 48 hours after dosing. The most common adverse events reported in greater than 20% of subjects receiving AV7909 across the 3 completed clinical studies were various forms of injection site reactions. Adverse events associated with CpG 7909 as reported in a number of reviewed infectious disease vaccine trials are considered to be associated with activation of pro-inflammatory innate immune responses at the injection site. Most reactions are mild to moderate in intensity, of short duration, and remedied with over-the-counter analgesics. In subjects who received AV7909 as well as the other CpG 7909 adjuvanted infectious disease vaccines, the vaccines were generally well tolerated with a low rate of vaccine discontinuation because of adverse events. In reviewed trials, rash, positive anti-nuclear antibody, generalized pruritus, urticaria, and fever have been reported as reasons for study discontinuation. No vaccine-associated deaths or serious adverse events have been reported in AV7909 trials or other infectious disease vaccine trials that use CpG 7909. It is important to note that these safety studies were all conducted in healthy adults aged 18 to 50. There are no data on the use of this vaccine or other adjuvanted CpG 7909 vaccines in children or other special populations, including persons greater than 65 years of age. Here is a timeline for the biologics license application submission provided by Emergent BioSolutions, showing the studies that are underway or planned to start in 2019. Non-clinical studies will include safety studies in pregnant and juvenile rats. A phase 2 clinical trial is being conducted to assess the safety and immunogenicity of AVA and AV7909 in adults greater than 65 years of age compared to adults 18 to 50 years of age, with preliminary results anticipated in the second or third quarter of 2019. Approximately 200 adults aged greater than 66 and 100 aged 18 to 50 will be enrolled in this study. The main study goal is to determine optimal dosing of AV7909 in elderly population via the evaluation of 3 different post-exposure vaccine schedules. A phase 2 drug vaccine interaction study is planned to investigate whether co-administration of AV7909 with ciprofloxacin or doxycycline affects antimicrobial pharmacokinetics or AV7909 immunogenicity in 210 healthy adults with results anticipated in 2021. A phase 3 randomized double-blind clinical trial to evaluate lot consistency, immunogenicity, and safety of a two-dose AV7909 series administered intramuscularly at day 0 and 14 in 3,850 healthy adult subjects is planned to start in 2019. We anticipate that this work group will reconvene in 2021 to review these data. Now I will go over the work group's discussions. The work group felt that the data show that AV7909 generates a similar to better immune response when compared to AVA given by the intramuscular route of administration over the time points reviewed, and would provide similar protection after exposure to aerosolized Bacillus anthracis spores. The data suggests that 2 doses 2 weeks apart produce a rapid response, providing the highest level of protection early, while 2 doses 4 weeks apart provide a higher sustained response. However, there is limited safety data available. Therefore, until there are more safety data available, the work group was not in favor of a preferential use of AV7909 over AVA. However, given the high mortality associated with inhalation anthrax, the work group felt the benefits of providing prophylactic vaccine outweighed the potential risk of AV7909. The work group supported the use of AV7909 if supplies of AVA are exhausted or unavailable once pre-EUA package has been accepted by FDA. The work group was also concerned that there were no safety data in children or other special populations. However, again, given the high mortality associated with anthrax, the work group felt the benefits of the vaccine outweighs the potential adverse events in these populations and would be an option for post-exposure prophylaxis if AVA supplies are exhausted or unavailable once the pre-exposure package has been accepted by FDA. Now I will provide proposed wording for the policy update. AV7909 is scheduled to become part of the U.S. government's Strategic National Stockpile by July 2019 and is currently under consideration for use under an emergency use authorization protocol. AVA is preferred for post-exposure prophylaxis for potential exposure to aerosolized Bacillus anthracis spores, as it is licensed for this indication. Additionally, AV79 safety data will be reviewed by ACIP as they become available, and recommendations on preferential use will be updated as needed. However, based on the limited safety data and immunogenicity phase 2 data, AV7909 appears safe and elicits a robust immune response in healthy adults. AV7909 could be an option for post-exposure prophylaxis in persons exposed to aerosolized Bacillus anthracis spores. As with AVA, antimicrobials should be taken for up to 60 days in conjunction with vaccine. Additional immunogenicity data will be reviewed by ACIP as it becomes available, and recommendations on antimicrobial duration will be updated as needed. CDC guidance for AV7909 will include statements on dosing schedules and special populations. So that concludes the informational presentation on AV7909. Are there any questions from the committee? Yes, sir.
Dr. Walter.
Yes. So if I understand correctly, both AV7909 and AVA have the same amount of antigen. That's correct?
Yes.
Yeah.
Yes.
And they're both made by the same manufacturer. Is that
Yes.
correct?
Yes.
Maybe I'm misunderstanding how the stockpile works, but I guess I don't quite understand how that would increase the supply?
Well, so we have a set amount of AVA in the stockpile. We have, we have a set amount of AVA in the stockpile that is expiring. There is no plan to buy more AVA. So AV 7909 will be coming into the stockpile. So over time, the balance will shift from more AVA to more AV 7909. And by that time, we hope that we have, more data so we can make a preferential decision on the use.
So I just want to provide a point of clarification. The purpose of this presentation and the information being included in the updated recommendations, and Willie, correct me if I'm wrong, is to ensure that states use this policy, this recommendation and report for their planning. And so we want them to have information available. However, in an event, if there's a widespread release and we need to use this product prior to the product being licensed, we would have an emergency meeting and vote at that time for use of this vaccine. So there's information being included, but we are not recommending this vaccine until there's either further information and the vaccine is licensed, or in an event, if we would have an emergency meeting. Is that
Yes.
accurate?
Any other questions? Dr. Fry?
Maybe it might be helpful for the group to understand, and I want clarification myself, Willie, that the AVA that is in the stockpile is older vaccine and maybe has reaching its
That is
age
true.
limit.
The AVA has expiration dates, and it is, I believe it is on a expiration date extension program, but the thought is that we want to move away from that. And based on the logistical advantages of AVA, we're sort of wanting to move towards that because we believe that it can give a better response, give better protection by giving the vaccine over a shorter period of time, and the adjuvant boosts the response.
Dr. Lee?
Thanks to Dr. Brower and to the work group for the really thoughtful discussions to date. I'm wondering if the work group will consider age-specific recommendations, in part as data start emerging, as if we ever get to an event, and whether or not it would be different for pregnant women and children versus for the adult population.
Oh, is that?
All right, just to clarify,
Yeah.
I'm just thinking about the understanding the benefit-risk balance in those populations, given what we know today, understanding that that information will probably change over time.
Yes.
Dr. Walter?
Yes, is AVA still being manufactured?
Actually, I don't. I mean, they have the capacity to make it, and yes, AVA is still going to be made for pre-exposure prophylaxis. So the answer to that is yes.
Dr. Bennett from Emergent Biosolutions, do you have a comment to make on that? Is he here? No comment. Okay, thank you. Dr. Szilagyi?
Yeah, thanks for a very nice presentation. Could I just get a better sense of this concept of as this AVA stockpile is exhausted? Do you mean in the country, or is there a resupply? Is there sort of a worldwide redistribution plan, or do you mean in local areas? I'm just trying to get a sense for how that decision
No, it
made
is.
that the AVA is
It is the U.S. government's stockpile. This is so AV 7909 is not anticipated to be used by anybody but the U.S. government.
And other countries or other? Is there some agreement with other nations or other stockpiles?
That would be above my pay grade. I don't know.
Any other questions from the voting members? Go ahead, Dr. Atmar.
I'd like to come back to Dr. Lee's comment in that I don't know that there are going to be data available in pediatrics or other special populations, although I think the IOM has concluded that it would be reasonable to conduct studies in pediatrics, for example, patients. I don't know that any are planned, and there are still ethical considerations, in those kinds of discussions. So I don't know that we're going to have more than the information will come from adults.
I mean, I would agree with that I believe, if using my crystal ball, I believe that what would happen is that we would administer it under an IND, just like we do AVA, if it came to the point where we needed to use AV 7909.
Dr. Lee?
I just wanted to follow up. Thank you. In a post-exposure prophylaxis setting, it seems to me the benefit risk would be highly in favor of the benefit of giving it in the absence of additional data. I'm just more thinking about the overall supply and the balance of that supply over time. So if there is the availability of the AVA alone, that might be reasonable to consider.
Dr. Fry?
Yes, thanks. There might be some CPG data in pediatric populations out there that with different vaccines. I'm not exactly sure about that. It has been a kind of a controversial has been a controversial adjuvant in its earlier days, but there's been, since that time, many studies that have showed it to be effective and thus far safe. The other, I just wanted to also agree with what Dr. Lee said. For example, with smallpox vaccine, we would give it to children and pregnant women if it was thought emergent.
And I'll just add to that CDC does have protocols in place in the event of doing a substantial amount of safety and effectiveness data collection around implementation of children, if that ever needs to happen.
Dr. Stevens?
Just to follow up on the CPG comment, I believe, though, that this is a new CPG that has not been used extensively in other vaccines. Can you comment on that, Wally?
Yeah, there are no licensed vaccines that use this particular adjuvant. However, there have been trials in, I believe, malaria vaccine and hepatitis B vaccine that used this adjuvant, and we looked at those studies, and they did not give any signal to indicate that there was anything more than some mild to moderate adverse events and no serious adverse events. But none of those vaccines are licensed. I don't know where they are, if they stop moving forward or where they are.
Dr. Bennett or someone from Emergent Biosolutions, would you like to comment about that new CPG?
Hi, Sean Bennett, Emergent Biosolutions. Yeah, I can confirm what Dr. Bauer said, that the CPG 7909 was evaluated in previous investigational vaccine trials. As far as we know, none of those have continued development. However, there is limited pediatric safety data from Heplisav-B, which uses the 1018 ISS, which is a similar mechanism of action.
Thank you for those comments. Any other questions or comments from the voting members? Any questions or comments from the liaisons? All right, thank you. Okay, next presentation.
Okay, yes, we'll just move right into the next presentation. So here's the outline for the presentation on anthrax vaccine absorbed, or AVA, for pre-exposure prophylaxis booster dose interval discussion. So It is important to note for this discussion that AVA is approved for pre-exposure prophylaxis in persons at high risk of exposure to Bacillus anthracis, such as laboratory workers handling Bacillus anthracis or veterinarians working with potentially infected animals. The policy question we are asking today is related to persons not at high risk, but may in the future be at high risk of exposure. Thus, the policy question is, can persons who are at current high risk of exposure to Bacillus anthracis spores maintain adequate immunity by being boosted with AVA every 3 years after immunological priming, with the caveat that if they were required to enter a high-risk area, they would receive a booster with or without antimicrobials depending on the timing of their last booster dose. The population of interest is persons aged 18 or older with potential future but not current exposure to aerosolized Bacillus anthracis spores. The intervention is a 6-month priming series at 0, 1, and 6 months, followed by boosting every 3 years with AVA, and compared to the current licensed AVA pre-exposure prophylaxis vaccine schedule, the outcome of interest is protection. Before presenting the data to support the policy change for this vaccine, I would like to provide some background information that is important to understand the pre-exposure prophylaxis anthrax vaccine recommendations. I have already provided a description of AVA or BioThrax. However, for this presentation, we're discussing the vaccine schedule for pre-exposure prophylaxis rather than post-exposure prophylaxis as in the last presentation. AVA is licensed for pre-exposure prophylaxis of anthrax in persons 18 to 65 years of age at high risk of exposure and is given by the intramuscular route as a 6-month priming series at 0, 1, and 6 months, with booster doses given at 12 and 18 months and annually thereafter. This vaccine is quite old with a long history. In the 1950s, the vaccine was made at Fort Detrick from a cell culture filtrate and precipitated with alum. This is the Wright or Fort Detrick formulation, which was studied extensively by Dr. Phil Brockman for prevention of anthrax in textile workers exposed to animal hides contaminated with Bacillus anthracis spores. In the 1960s, the manufacturing process was improved, resulting in an increased protective antigen concentration, purity, and potency. This new formulation was referred to as the Lansing formulation and produced by the Michigan Department of Public Health in Lansing, Michigan. In the 1970s, the Lansing formulation was licensed using data from the Brockman studies. In 2008, the 2-week priming dose was dropped and the route of administration was changed from subcutaneous to intramuscular for pre-exposure prophylaxis. In 2012, and subsequent to the last ACIP review, the priming series was changed from 5 doses to 3 doses at 0, 1, and 6 months, with the last 2 priming doses changed to booster doses at 12 and 18 months, and then an annual booster thereafter. This enabled laboratory workers or deployments to high-risk areas to occur after 6 months rather than 18 months under the old priming schedule. AVA was last reviewed by ACIP in 2009 and recommendations were published in 2010. ACIP did not recommend that emergency responders routinely receive anthrax post-exposure prophylaxis. However, they did suggest that emergency responders on a volunteer basis could opt in to receive pre-exposure prophylaxis. They also noted that the data suggests an increased booster interval does not decrease the ultimate immune response. As we discussed previously, Bacillus anthracis is considered one of the most likely pathogens to be used as a bioweapon. Modeling scenarios show how a large release of Bacillus anthracis spores from a commuter train traveling through a densely populated area could theoretically expose tens to hundreds of thousands of persons to anthrax, resulting in a public health emergency. If this type of event were to occur, having a group of emergency responders with a primed immune response and only requiring a booster dose to begin work in the infected area would greatly improve the surge capacity for the public health response. Now I will go over the public health importance of this policy review. Currently, AVA for post-exposure prophylaxis is only indicated for persons currently at high risk of exposure to anthrax. However, there are groups of persons, such as the military, who may need to enter an area of high risk, then leave, and may not return for several years. Also, there are persons, such as emergency responders, who are not at current risk, but might be required to enter an area of high risk on short notice. New data on immunogenicity following extended booster intervals suggest in these situations, persons can have a booster interval of greater than 1 year and maintain a robust amnestic immune response to a booster dose. This would potentially reduce the number of adverse events by decreasing the number of vaccinations and decrease logistic issues related to getting emergency responders deployed should a mass anthrax event occur. If approved, an updated policy statement will be published that will combine information from the previous 2010 MMWR document with updated indications and dosing schedules for AVA. Now I will review the studies that provided the basis for the extended booster dose interval. The main concern with extending the booster interval is the level of protection at the pre-boost time point when antibody levels are at their lowest. The correlates of protection approach was designed to evaluate protection at those time points, which should be the minimal protective level for each schedule. Since inhalation anthrax is very rare in humans, we cannot directly assess the effectiveness of AVA for pre-exposure prophylaxis. Instead, we use the correlates of protection model to estimate human survival at vaccine-generated anti-PA IgG concentrations compared to non-human primate anti-PA IgG concentration in survival data. The animal antibody concentration in survival data came from the Quinn study, in which non-human primates were given AVA at full strength or at various dilutions at 0, 1, and 6 months to generate a range of anti-PA IgG concentrations. The animals were then challenged with 200 to 400 LD50 Bacillus anthracis spore concentrations at 12, 30, and 52 months. The antibody concentrations and survival data were placed in a logistic regression model to generate a survival curve. This study showed that 3 intramuscular priming doses elicited sustained production of functional PA-specific interferon gamma and interleukin-4 secreting T cells, lymphocyte proliferation responses, and memory B cells for the study duration. Chen et al. Performed a comprehensive analysis of 21 humoral and cell-mediated non-human primate immune response variables at various time points. The anti-PA IgG level at the last available time point before challenge and lymphocyte stimulation index at study months 2 and 6 were identified consistently as correlates of protection. Anti-PA IgG levels and anthrax lethal toxin neutralization activity at both the time of exposure and 7 months were predictable and accurate metrics for correlating vaccine-induced immunity with protection against inhalation anthrax. The model indicated that even with very low levels of circulating antibody at the time of challenge correlated with significant levels of protection. All vaccinated non-human primates had measurable antibodies at month 7. By time of challenge, some of the 1 to 10 or lower dilution groups no longer had measurable serum anti-PA-IgG levels, and some of the animals with undetectable antibody levels still survived. Fisher's exact test was used to compare the overall survival rates between all pairs of challenge times for the vaccinated non-human primates. There was a statistically significant difference between the survival of animals challenged at 12 months and that of animals challenged at 30 months. However, no statistical difference were evident between animals challenged at 12 months and 52 months, or between animals challenged at 30 months and 52 months. The Quinn study showed that the 3-dose priming series at 0, 1, and 6 months with a human dose and dilutions of up to 1 to 10 of AVA provided levels of protection from 60 to 100% against inhalation anthrax for up to 4 years in non-human primates. In general, serum anti-PA-IgG and TNA responses remained significantly above controls through 50 months, which was the last time point measured. It also showed that protection was achieved even with diluted vaccine doses. The human data came from one main source. The Wright paper looked at the licensed priming schedule and increasing booster dose intervals that provided the immunogenicity data for the correlates of protection model. Data from the 2 Pittman papers support the robust amnestic immune response seen in the Wright study. This study shows the different arms and number of arm participants used to assess the booster dose intervals in the Wright study. The 7IM arm represents the current licensed pre-exposure prophylaxis schedule, as the 2-week dose was dropped from the schedule in 2008. The 4IM arm represents the proposed pre-exposure prophylaxis schedule with an up to 3-year booster interval. In the Wright study, all groups produced high immune response by 7 months and there were no statistically significant differences between groups at that time point. Only 2 out of 1,303 vaccinated participants did not produce detectable antibodies at month 7. Both individuals dropped out of the study before receiving another dose, so there are no follow-up data. All groups and all remaining participants responded to booster. The 5IM and 4IM groups showed gradual receding levels of antibody in the period between boosts relative to the 7IM schedule. Geometric mean antibody levels remained well above background through month 42 in all groups. At month 42, all of the 7IM cohort had detectable antibodies. 97.9% of the 5IM group had detectable antibodies, and 80.2% of the 4IM group had detectable antibodies, significantly higher than controls. Response to the group or the month 42 boost in the 4IM group was nearly double that of the 7IM group and statistically significantly superior. The 5IM group was also higher than the 7IM group, but not statistically significant. The aim of the Pittman study was to compare the level of persistence of anti-PA-IgG concentrations and toxin neutralization response in persons who had a delay of up to 7 years in receipt of the 6-month dose compared to those that received the dose on schedule. The delayed cohort in the Pittman study was non-inferior to the on-schedule cohort for both anti-PA IgG and TNA ED50 at day 28 and 180 post-vaccination. In fact, the delayed cohort was superior to the on-schedule cohort on days 28 and 180 for both mean anti-PA IgG concentrations and mean TNA ED50 titers. Furthermore, antibody levels receded significantly faster in the on-schedule cohort than in the delayed group, thus demonstrating a reason to delay the booster dose. In summary, the data presented confirms that a 3-dose IM priming series administered at 0, 1, and 6 months, followed by boosters at 18 and 42 months, or a single booster at month 42, establishes robust immunological priming and sustained immunological memory. The correlates of protection model predicts high survival estimates with even the most reduced boosting schedule. As expected, an increasing period between booster results in lower levels of anti-PA IgG just prior to vaccination. However, the persistence of quantifiable anti-PA IgG and the exceptional recall response to a booster administered at either months 18 or 42 are noteworthy. The greater interval between boosters generated a significantly higher response, which, if assuming a similar decay curve, should provide higher protection between booster doses. Increasing the intervals between booster doses could or should decrease the frequency of vaccine-related adverse events and decrease operational costs of administering the vaccine. These data, together with duration of protection studies in non-human primates, suggest AVA established long-term antibody-secreting plasma cell populations and robust immunological memory manifested by rapid and high amnestic responses. Now we'll go over the work group discussions. The work group discussed a 3-year booster interval for persons at current high risk of exposure to Bacillus anthracis. The work group felt that persons at continuous high risk of exposure, that the higher titers just prior to boosting were the most important factor when deciding the booster interval. This is provided by an annual booster and thus were not in favor of extending the booster interval to greater than 1 year for individuals at current high risk of exposure. However, in persons not currently at high risk of exposure, but who may in the future be at high risk of exposure, the work group felt that the data shows that a booster interval of up to 3 years provides a robust amnestic immune response. There are also limited data suggesting the booster dose could be up to 5 to 7 years, but more data are required to make a recommendation for greater than 3 years at this time. The work group also felt that we should address a gap in the recommendations for persons who are in the process of receiving the 6-month priming series and are required to enter a high-risk area prior to completing the priming series. These recommendations came from review of the data on immune response to the AVA pre-exposure prophylaxis priming series that showed that 3 doses provide priming for an amnestic immune response, and from the AVA post-exposure prophylaxis data that showed 3 doses given 2 weeks apart provides high levels of protection. There are no data on the effects on the effect on the immune response for starting pre-exposure prophylaxis by the intramuscular route and switching to the subcutaneous route to join the post-exposure prophylaxis schedule. However, there is no reason to believe that the immune response would be as adversely affected by mixing the routes of administration. While in the high risk area, the licensed post-exposure or the licensed booster schedule for high risk exposure would apply. Now we'll go over proposed wording for the policy change. AVA is licensed for prevention of anthrax in persons at high risk of exposure to Bacillus anthracis. There are no proposed changes to this indication. We are proposing a booster interval for AVA that is longer than the licensed booster schedule for persons who are not currently at risk of exposure, but who may need to deploy to a high-risk area quickly. While in the high-risk area, the licensed booster schedule for high-risk exposure would apply. We are proposing for persons who lack current but may have future high-risk exposure to Bacillus anthracis, AVA may be given as a intramuscular 3-dose priming series at 0, 1, and 6 months, followed by an intramuscular booster every 3 years. After receiving the 3-month priming series, persons who have not had a booster dose in the last 6 months but need to enter an area where Bacillus anthracis is suspected to be in use would be given an IM booster dose and either wait 2 weeks to enter the high-risk area or, if required to enter immediately, take antimicrobial prophylaxis for 2 weeks. Persons who have not completed the priming series for pre-exposure prophylaxis with AVA who are exposed to aerosolized Bacillus anthracis spores should join the post-exposure prophylaxis schedule. This table provides information on additional AVA doses needed based on the number of pre-exposure prophylaxis doses already received and the recommended antimicrobial coverage. Here is the policy change the ACIP committee will vote on later today. To maintain memory response, a booster dose of AVA should be given every 3 years to persons who receive an AVA priming series if they lack current high-risk exposure to Bacillus anthracis. This concludes the presentation on AVA booster dose interval. Are there any questions from the committee?
This session is open for questions by the committee. Comments? None. Okay. Dr. Atmar?
Just to clarify, the working group is requesting that this, already there's a recommendation for off-label use of the vaccine for, groups that are worried about potential future exposure, and such as emergency responders. And so this is providing clarification of how often one can boost those individuals to try and maintain some immune memory. And so it's an off-label recommendation for an already off-label use of the vaccine. So we just want to make that clear.
Yeah, and to provide even additional clarification, this is a group that is not, and please correct me if I'm wrong, not recommended to receive the vaccine, but there's sort of a permissible language around using the vaccines. Is that?
Yes, well, the 2010 recommendation said that they could voluntarily receive it. So yes, we're just, as you state, we're just providing some guidance about how, if you wanted to do that, how to go about it, and we think that this would be a better use than trying to get it every year.
Dr. Moore?
Thank you. And I just wanted to follow up to clarify my understanding about future work group considerations for those who are at ongoing high risk, that if there were more data available on the sustaining of the titers following booster doses, that there might be an opportunity to space those boosters out for those at ongoing high risk, should more data become available to reassure us that an interval greater than an annual interval for those people would also be appropriate? Is that's something that's in the future to be looked at?
Well, if I understand your question correctly, that would we look at data to increase the booster dose for people who are at current high risk?
Yes, the booster dose
Okay.
intervals, as I understood, that's not on the table right now.
It is
because there
not
are
on-
not sufficient data, but in the future, were there, given that we've been seeing some encouraging information here, there might be studies that would reassure us enough to space those out
Well,
in the future?
FDA has seen the data and they did not want to extend the booster dose for people at current high risk.
Right.
Yes, I assume that if data came up and we were going to work with DoD, who have some opportunities to maybe look at that question and generate some data. So if promising data came up, we would certainly present it, but we might have a high bar to go over.
Sure, okay. It seemed like there was an opportunity for additional studies, currently not there, but could be there in the future, and that might be a benefit for those if there were additional data that supported that decision.
Yes, ma'am. I agree with that.
Dr. Atmar.
Just to address that, though, that's the Wright study looked at intervals of 2 years and 3 years and suggested that, an interval longer than 1 year led to a proportion of the persons who were on this longer interval, 2 years or 3 years, being potentially susceptible. And so that was considered to be an undue risk for individuals that have continued exposure. So it's unlikely, based on the Wright data with AVA, so with that vaccine, that such data would come forward in the future. Certainly, if they were generated, I'm sure the work group would reconsider it, but I think we already have some pretty good data suggesting that's not likely to be the case.
Right, that's why I said it would probably be a high bar to change that.
And I was honestly thinking about after that first annual booster dose, then it looked like you had a really, really nice response after that first booster dose and a slower degradation. So it's not an issue for discussion right now. I was just wondering what it would take to get there. Thank you.
Dr. Lee.
It's more of a comment. So thank you again for the thoughtful deliberation by the work group. That it seems to me that going from more of a permissive to a regular recommendation would be helpful, because it means that we would have better workforce readiness to go into the field to respond to these events. Is that part of the intention with this, to go from, to make it clearer what the recommendation is for a greater proportion of the workforce?
Well, there are certainly emergency responders, first responders, especially in certain areas that would be high target, that would probably take advantage of this, and spreading out the booster dose interval would make it more appealing to them. And as AVA expires and leaves the stockpile, there has been some consideration of making it available to first responders so that they could be prepared for an event. So this is sort of why we are wanting to give some guidance on how that might occur.
Dr. Atmar.
But I think in answer to your question, I think it's still permissive. It's not recommended. And so the booster is permissive, but the way it's stated, it says to maintain immune memory. So it's, for those who want to maintain immune memory, then the booster is recommended. But it's still a permissive recommendation for the off-label use of the vaccine for groups like emergency responders that want to take advantage of access to the expiring vaccine.
Thank you for the clarification.
Any other comments or questions from the voting members? Any comments or questions from the liaison groups?
Linda Eckert, ACOG. I just wondered if there's going to be any pregnant women that are going to be in these studies, or postpartum breastfeeding women, because you had mentioned potentially using the vaccine in all situations.
So for AV 7909 exactly what studies are you talking about?
I was thinking of the second set where you were looking at the booster after the priming.
Okay, well, right now we are thinking of collaborating with DoD, and they do have people who are inadvertently vaccinated during pregnancy, and they would certainly be enrolled if that were to occur. Or that data they wouldn't be enrolled because they weren't pregnant, but we would look at the data as they were pregnant.
Any other? Dr. Kimberlin?
David Kimberlin, AAP. Can you back up one slide? Is this what's the vote's going to be? I mean, this wording is what's going to be voted on later on.
Yes.
If a movement,
Yes.
motion is made. Thank you.
And just to clarify that the permissive language around people who are not at increased risk is for persons 18 years and older, as Dr. Bauer had in an earlier slide.
Any other questions or comments from the liaison group? Oh, yes, please, Dr. Baker.
Just a question about the words. Should be given does not sound very permissive.
Dr. Atmar.
I think that the qualifiers, to maintain memory response, it should be given. It's not saying that it has to be given, but the permissive part is the qualifier to maintain memory.
Dr. Baker.
But it says,
Right.
That's
if
right.
they lack high-risk exposure. So these are presumably low-risk people.
So I
Correct.
think that this recommendation would be, when it's published in the full recommendation and report, it would be language below the language around use of this vaccine in persons not at high risk, which is permissive language. Is that correct?
Yes, absolutely.
Dr. Stevens.
Two comments. One is about risk. I mean, these people have already been vaccinated, so there must have been some anticipation about risk in these individuals. I think this is simply extending the booster to a longer interval. I do have a question, though, about the word maintain. It's really eliciting a memory response. It's not necessarily maintaining. The memory response is already there. You're eliciting a memory response as opposed to, quote, maintaining it.
Excellent point. Are you asking that the language be changed?
That would be my recommendation.
Very good.
Okay, we can do that.
Dr. Hunter.
I have to say I share Dr. Baker's concern about the should, because I have a feeling this could get excerpted, and people could leave out part of this when they copy it to their friends and their colleagues. And I think it should not say should. I think it should say may.
Yeah. I was actually going to say exactly the same thing. I think it's actually accurate, but it could be misinterpreted because of the word should.
Well, if that's how the committee feels, we can make that change.
Dr. Zonoway.
I'm just wondering, is it should be or is needed? So because I keep wondering when I read that and it says you need that from the data that is available. So whether it should is a decision that the provider makes, but is it needed?
Dr. Lee.
Can I ask maybe that we have the permissive recommendation up above when we come back to do the official vote later, and then we can look at the wording in that context?
Okay, yes, we can do that.
All right. So with the modifications suggested, do I have a motion to accept? Go ahead, Dr. Stevens.
So I move to accept as recommended.
Okay. Second, Dr. Lee. Are there any other comments or questions?
Do you want to say? You say
Oh, sorry, Dr. Aronson, forgive me.
It says idea.
It says to elicit memory. I think the correct term would be to boost.
And I do just want to make sure the committee does understand that we can make some small language modifications at the time of a vote that don't change the intent of the motion being made, but help for clarification purposes.
I think we can also bring this back with a modified wording for the vote. Are there any other comments from either the voting members or the liaisons? Okay, very good, thank you.